It's our pleasure to be here with you this afternoon, and we look forward to shedding as much light as we can on what's been happening in Washington. And just by additional background, I grew up professionally as a hospital lawyer and lobbyist, and Miranda grew up professionally as a physician lobbyist and professional, and so we just have that additional background that may be helpful for you. I've spent half my life inside of hospitals before joining Holland Knight. Anything else you want to add?
Yeah, just look forward to connecting with you all, and we'll have some time for questions and answers at the end, but we want this to very much be a discussion and a dialogue, so please feel free to let us know any questions you have as we go along. Thank you.
And if we get into Washington speak, which is its own strange language, please feel free to stop and say, I'm sorry, what is that? Because it's easy to do.
And I think just quickly, before we begin, it might be helpful just to have an understanding of who's in the room, so we frame this in a way that's most meaningful for you all. So if there are any clinicians, practitioners in the room, if you could raise your hand. Wonderful, thank you. And then those in the community, or if you're affiliated with the hospital in some other capacity. Great. Patients, friends of patients. Wonderful, thank you.
Okay.
Great.
Super. So just to give you an overview of the presentation, we're going to talk very briefly about the new administration, the Trump administration, in terms of who he's put in place with regard to healthcare. We're going to touch very briefly on the budget that was just passed and enacted. We're going to spend most of our time talking about the Republican quest to repeal and replace the Affordable Care Act. Then we're going to talk about some other legislative issues that are out there and some regulatory issues that are out there as well, particularly for some of the clinicians who may be interested in a little bit more of the detail. We won't spend too much time on it, but we wanted to start there. So with that, we will start with the new administration in healthcare.
Sure. So, as you all know, we've ushered in a new administration as of November last year. Most notably, Dr. Price is now at the helm at Health and Human Services. He is only the third physician to hold a position since the inception of HHS. And I mention that because it will most likely inform a lot of sort of his decision making and some of the things that are happening in the regulatory arena under his discretion at CMS and some of the other agencies. Seema Verma is the new administrator at CMS. She actually led Medicaid efforts in Indiana, and so she has a very deep Medicaid background, and that's one of the main reasons that she was brought over to lead CMS. So I think people are still trying to sort of get a sense of what her knowledge and understanding is of issues outside of Medicaid, but I think for the immediate future, she's going to be largely focused in the Medicaid space. Nick Mulvaney is leading up the Office of Management and Budget. They serve a multitude of purposes, but do a lot of review of regulations that are being advanced through some of the agencies we just mentioned.
And he brings a very conservative bent. You've heard, if you've been reading the papers, something about the Freedom Caucus in the House, which is the far-right group. He was a member of the Freedom Caucus before he went to the administration, so he has been critically involved in the development of the House Republican repeal and replace legislation. So I loved Schoolhouse Rock. For anyone, old enough to remember it, the typical process that we all learned, right? You have a House bill, you have a Senate bill, goes through the committee process, and then they have a conference committee, and most bills never actually make it through that process or make it to the president. There are all different kinds of machinations in terms of how that occurs. And the original enactment of the Patient Protection and Affordable Care Act did not go through every one of the normal processes. It certainly worked its way through the committee process, but there was never a conference committee on it for a variety of political reasons, and it was ultimately enacted through what we call the budget reconciliation process, and we're going to talk a little bit more about that. The same process that was used to create the Affordable Care Act is the same process, the same budgetary process that is being used by the Republicans to, in their words, repeal and replace it. And the difference is when you're using this special budget process called budget reconciliation, what it means is that in the Senate, they only need 51 votes. But there's a catch that makes it difficult for whichever party or on a bipartisan basis. When you're in the budget reconciliation process and you're utilizing this particular budgetary procedure, yes, you only need 51 votes, but you can't affect policy. The only provisions that can be included in a budget bill like this have to have an impact on spending or on revenues. And so that becomes, it was tricky for the Democrats, it's tricky for the Republicans, and so that's why there's some things that you didn't see or will see as part of the repeal and replace effort that we're going to spend some time on.
And I would just note, as we're still very much at the infancy of this, the discussion very much turns now to the Senate, but they will likely, as we'll discuss, make some pretty significant changes. So what you've sort of seen in the news is by no means a final product.
And we'll probably say that about 4 times in the presentation. What you see is not what's going to come out the other side. And in fact, just to underscore what Miranda's been saying, there are a number of, they're writing their own bill from scratch in the Senate. They may take a piece here or a piece there, but they're taking a different approach than the House took. So you want to talk briefly about budget?
Sure. So you may have heard some rumblings on the news in the last week that the government was in fear of shutting down had Congress not acted and advanced a budget. They finally did last week. Here you'll see some of the components that have impact in the healthcare space. This is not sort of the skinny budget you may have heard about that came out earlier in the year, which is essentially the administration's sort of wish list of what they would like to see advanced. This is a more robust, comprehensive bill that funds the government through September of this year, and then Congress will again have to act. But there's $2 billion increase for NIH, for the National Institute of Health. A lot of that was part of the 21st Century Cures Act, which you may have heard about, which passed last year, which was an effort to really sort of move forward with the innovative cures and things like precision medicine and things that could really advance some of the more curative aspects of therapies. The bill did not include any funding for the wall, that there was a lot of controversy around that, where the administration wanted funding included, but after a lot of negotiation back and forth and Democrats pushing quite aggressively, that was not included. So that passed the House on the 3rd and was signed into law on May 5th.
And I would just add, with regard to the 21st Century Cures legislation, you know, the press very often reports on the division, but 21st Century Cures was an astounding example on a bipartisan basis of Republicans and Democrats from the very beginning coming together to enact an overhaul, so to speak, of the development of innovation in treatment in this country. It doesn't solve all the world's problems, but it was a big leap forward. It just isn't always on the front page of the San Francisco Chronicle or the New York Times or the Washington Post. Okay, now we're going to move to the meaty stuff. But just starting out, cost of care, access to care, right? Huge issue. Quality of care is something, there are a whole series of provisions included in the Affordable Care Act that, as for those of you who are clinicians or administrators in the room, deal with every single solitary day. Some of those were originally proposed by the Bush administration, were included in the Affordable Care Act, and they're not going anywhere. We'll spend a little bit more time with that. You want to keep going?
Sure. And so obviously coverage is a huge issue that you hear as part of the discussion of the advancement of the AHCA. So addressing those that still remain uninsured under current law and what that would look like if the environment did change under a new piece of statute.
And the AHCA, so the ACA is the Affordable Care Act, Patient Protection and Affordable Care Act, sometimes called Obamacare. And the AHCA is the American Health Care Act as proposed by the House Republicans. So sometimes like I'll slip, going back and forth because it's only an H in the middle of it. But just go ahead.
So I'm sure something you heard on the campaign trail by both Clinton and Trump were around drug pricing and drug pricing transparency. There's obviously been a lot of concern with price gouging by certain pharmaceutical manufacturers and companies, and so there has been a huge effort, I think also on a bipartisan basis, to address this issue. And so that is something that you'll continue to see discussed outside of AHCA reforms, and is something that is being discussed now as Congress works on something called the User Fee Acts, around different biosimilars and pharmaceutical drugs. So that's a huge attention piece for Congress at the moment. Obviously, the opioid epidemic is something that's of grave concern to members across the country. As you saw on the previous slide, there was some funding advanced as part of 21st Century Cures to address this. There are a myriad of standalone bills currently in Congress to also address this from a funding perspective and also from a counseling perspective, and some other initiatives to address this chronic issue that we have. Then chronic care management is something that the Senate in particular has been very focused on, and Orrin Hatch, who is chair of the Finance Committee in the Senate, has really been dedicated to advancing legislation in this space. Cost transparency is something I'm sure you've heard a lot, especially at the hospital level, so patients have a better understanding of their cost before they have a service administered at a hospital. And again, that also goes back to the drug piece, having a better understanding of drug and therapy costs. Health IT has been an issue that was of great importance in the previous administration that I think will be carried over in this administration, looking at things like telehealth and ways to provide access to patients in rural communities who might not have a brick and mortar hospital near them. There are other initiatives like electronic health records and things that help with interoperability of those records that are something that Congress continues to engage in, as well as the agencies. The clinician shortage is something I'm sure you've all heard about and maybe experiencing in some capacity, especially with thoracic surgeons is an area that there is a huge shortage. Primary care in different parts of the country have experienced shortages, and especially with the baby boomers retiring, it's continuing to be an issue of concern.
Yeah, we've created a number of medical schools in this country, but we haven't created additional residency slots. So we've got a pipeline problem, and the Congress recognizes that there's a problem, but the cost of providing funding for graduate medical education to the Medicare program is very substantial, and for them to make changes would cost billions and billions and billions of dollars, and so they have not yet addressed it. But on a bipartisan basis, they recognize that it's an issue, they just haven't yet taken it on. And the biggest issue is out there, and we're going to spend more time talking about this, is in some parts of the country, instability within the marketplace. California, I think, has been the beacon on the hill in terms of stability, more so than the rest of the country. And there are pockets, and we're going to show you a slide so you can really get a visual around it, where that has been a much bigger issue than it has been in California. Okay, here we go, health reform round 2. Just a refresher on the major provisions of the Patient Protection and Affordable Care Act. So what you see there in red is basically those in the Medicaid program under 133% of the federal poverty level. So the law was designed to have everybody who isn't already covered under Medicaid be covered under 133% of the federal poverty level. And to grossly oversimplify, you're largely talking about childless adults, because folks with disabilities were otherwise covered, elderly individuals who are impoverished, children, low-income children, disabled children, and pregnant women, and then some coverage for adults. But really what the ACA intended to do was to say everybody under 133% of the federal poverty level would get covered by their state Medicaid program. And between 100, it's actually 100, there's some overlap, and 400% of the federal poverty level would receive subsidies, tax credits, and then some cost-sharing subsidies provided to insurers to provide affordable coverage that people would purchase through the exchanges. And California, obviously, cover California. Major provisions that you've heard much about: the ban on pre-existing conditions, a requirement that plans in the exchanges and on Medicaid cover 10 essential benefits in the actual plan. That's the first time we've seen a federal prescription for what should be included in certain plans. The health insurance exchanges that were set up based on the original Massachusetts model: individual mandate to purchase coverage, employer mandates to purchase cover for their employees over 50, low-income subsidies I talked a little bit about, Medicaid expansion I talked about, and then there were a variety of Medicare payment reforms.
So the ACA, as we're kind of going through a refresher of this, was a major source of insurance coverage. The Obama administration was very clear that one of the catalysts for this, in large part, was to increase coverage for those that did not have it, and to ensure that the uninsured tolls were being decreased and that we were covering more people in our country, which in large part has been an accomplishment of the ACA. And so you can sort of see the breakdown here between coverage of Medicare, employer-sponsored insurance. As Lisa mentioned, the ACA established the exchange market, so the marketplace here is reflected, as well as coverage expanded through Medicaid.
So the original intent and the way the law was written, the original Affordable Care Act, required states to expand as a condition, to expand up to 133% of the federal poverty level as a condition for Medicaid funding for the traditional individuals covered by Medicaid. And you'll recall that the Supreme Court, when they had their seminal ruling, said that that's unconstitutional and that the federal government cannot, in the words of the late Justice Antonin Scalia, put a gun to the head. And that was actually, when you look at that particular component of the decision, that was 6-3. So it wasn't just the conservatives on the court that took that position. And that's when we began this enormous discussion across the country as to whether states wanted to expand or didn't want to expand. But the intention was to cover everybody under 133% of FPL. So if you're in a state that didn't expand, and obviously California did expand Medicaid coverage, but if you're in a state, some of these southern mid states, you have folks under 100% of the federal poverty level who aren't covered by Medicaid and aren't getting subsidies in the exchanges to purchase coverage. So you've got a big gap in those states. And this becomes very important because what you have right now going on in the US Senate is a debate, even among the Republicans, because there are a number of states that expanded even under Republican governors and Republican legislatures about what to do now. So we're going to come back to that, but the visual here is important.
So as I mentioned, we did see the uninsured rate decline post the enactment of the Affordable Care Act, and California actually has a significantly lower uninsured rate in comparison to the rest of the country. The rest of the country sits around 10 to 11%. According to latest projections, California is around 7% according to the CDC. And so you can sort of see the reduction just from 3-4 years ago, a reduction of 10%.
So part of what is concerning not just the Republicans, but also the Democrats in terms of making improvements is what's happening in the marketplace in a number of parts in the country where there's insurance, basically the market is unstable. So this gives you a sense, and the Kaiser Family Foundation has tons of data, so we borrow liberally and reference them as our source. But in 2016, you can see that 7% of counties across the U.S. had only one exchange insurer that an individual can choose from, and in 1 year that climbed to 32%. This is the visual around it. So you can see where the orange spots are, you've got one insurer, and more recently there's been an entire pullout of Iowa, a number of counties in Tennessee where there's no insurer providing coverage. And since the law has a mandate that you either purchase insurance or pay a penalty, that becomes challenging and an issue that needs to be addressed.
And I would just note one slight implication of this is that this, where you don't have a lot of competition, we've also seen increased issues with network adequacy, and that obviously has implications for patients.
And price increases where you don't have the competition. So in terms of big picture options before the Congress, in terms of either repealing and replacing or making improvements to the Affordable Care Act, one option that they have is to do nothing. We think the result of that would be even greater market instability in parts of the country, as you saw develop. They could fix it. They could keep the central tenets of the law, retain the coverage gains and the reduction in uninsured that has been so dramatic and helped so many people, and seek to stabilize the marketplace. One of the things that I would note is most major pieces of legislation, whether healthcare or otherwise, typically get amended and amended and amended. And there's a reason for it, because when you enact a law of that magnitude, even if it's a smaller bill, they'll come back and make changes. There have been very, very few changes to the Affordable Care Act, primarily for political reasons. Next option is repeal it and not replace coverage, which is some on the very far right end of the Republican spectrum. Repeal and replace with coverage that is different from the coverage that is included in the ACA. I would venture to state that no matter what, I think they're going to need to deal with the marketplace issues that are occurring in other parts of the country.
And I would just note politically, in terms of the repeal and replace coverage, there's also the issue that they could attempt to in the Senate and just not achieve the votes that they need. So there's a little focus on that in terms of the Senate piece, but there's sort of the political piece of can they get over that hurdle in terms of getting the support that they need to truly repeal and replace.
And here's Paul Ryan, the House Speaker, who is very knowledgeable on healthcare issues. Whether you agree with him or you don't agree with him, he knows the issues. He served as chair of the Budget Committee, chair of the Ways and Means Committee. There are a number of members of Congress on both sides of the aisles that really do understand healthcare and are steeped in policy. They may differ about their policy approach or their political approach, but he is very knowledgeable on the issues. So what are the Republicans, from their perspective, seeking to do? So the first is they want to remove the individual and employer mandates, and what they're proposing to do, at least in the House legislation, is to replace that with a very strong, very big carrot, if not a little bit of a whip, with regard to continuous coverage. We're going to get a little bit more into that. This is a massive, we were talking about this before we started, this is a massive transfer of power, at least in terms of what the House proposed, shift back to the states with regard to insurance regulation and with regard to Medicaid, and it reflects their general view that states are in the best position to make decisions with regard to their citizens. And so it's just reflecting sort of their general governing philosophy. It would repeal the ACA taxes that help to fund coverage, the medical device tax, the pharmaceutical tax, the health insurance tax, and a laundry list of other taxes. It would repeal those. It would create major changes to the entitlement reform of the Medicaid program. I remember coming once upon a time back with Nancy and her team right after the Affordable Care Act was enacted, and we spent some time really educating what was in the legislation at that point. At that point, Medicaid was still smaller than Medicare in terms of number and in terms of cost. It has now exceeded Medicare in terms of the number of beneficiaries and the cost. So what are they doing? They are seeking to change the way that Medicaid is financed from the federal perspective, and they're repealing the enhanced funding for Medicaid expansion. And we'll spend a little bit more time talking about that. They want to replace the cost-sharing subsidies. So there are two kinds of subsidies that are provided in the ACA to help people purchase insurance for those that aren't otherwise covered by Medicaid. And one is a premium tax credit that is tied to an income. And the other is subsidies that are made from the federal government directly to the insurer to lower the cost of deductibles and co-pays, but it doesn't run through the individual purchaser. Covered life, it goes around them. So they want to change that. They talk a lot about choice and competition. They'd like to see more. They want to see the purchase of insurance that you could use your premium tax credits that they're proposing, at least in the House, outside of the exchanges. They want to create, in their view, a more robust marketplace. And they've talked a lot about trying to ensure that patients have a choice of doctors and hospitals and other providers. And to Miranda's point, in certain parts of the country, there have been network adequacy issues that they're seeking to address. Most importantly is to stabilize the insurance marketplace where it is faltering.
So in terms of Medicare, I think it's really important to note that this bill, and as Lisa mentioned at the onset, because it's under budget reconciliation and they're trying to advance this now in the Senate, there are specific rules about what can be included, and they have to be sort of cost revenue focused. So a lot of the focus has been solely on the Medicaid side and taxes. So there are no significant Medicare changes in the House bill that just passed. There might be efforts to address some of those things in piecemeal legislation outside of sort of this larger vehicle, but in terms of what was advanced in the ACA around Medicare payment and delivery reform, those things are very much here to stay. This does not change the donut hole or physician payment or Medicare Advantage or Medicare coverage in any way, and it certainly does maintain some of the things that I think patients and consumers were most supportive of in the ACA, like patient protections for children under the age of 26 to stay on their parents' insurance. And to Lisa's point, she mentioned pre-existing exclusions are also retained. We'll sort of touch on, I'm sure you've heard a lot of focus around that, so we'll sort of spell out where that's sort of addressed in a roundabout way in the legislation moving forward. In terms of policy changes, some of the things that you may have also heard on the campaign trail were the desire to sell insurance across state lines. That is not in this bill, and it does not eliminate the exchange marketplace that we discussed earlier.
Okay, so you heard, you would have to have been abroad if you didn't hear that they worked their way through the House process, through the committee process very quickly, and went to take the American Health Care Act as the House Republicans drafted it, to the floor. They got there and didn't have the votes. So they then spent the next 6 weeks trying to figure out how, from their perspective, they could get the votes to move the legislation. And within the Republican caucus, there were a number of issues that were challenging for them to navigate through, and those issues are still just as challenging for the Republicans in the Senate, even though the Senate, by and large, within the Republican majority, is more moderate than in the House, when you look sort of across a conservative spectrum. So the first is the Congressional Budget Office, which is the nonpartisan office, and its purpose is to provide information to the Congress in a nonpartisan fashion with regard to whether a piece of legislation will cost, how much, what the impact on coverage might be, and the CBO does its best. I can't imagine how difficult that job would be. They certainly made a number of projections with regard to the Affordable Care Act that weren't quite on the mark. Sometimes they get it right, sometimes they get it wrong, sometimes it's in between. But they came out and projected that 24 million folks, individuals, citizens of this country, would lose coverage under the American Health Care Act as proposed by the Republicans before they started to make some additional changes, including affordability of premiums they talked about, cost-sharing subsidies, the loss of those, and high-risk pools. There are some in the Republican circles that would love more high-risk pools, some in Republican circles, and the purpose of a high-risk pool for those who advocate for it is to take those with pre-existing conditions, high-cost conditions, and provide additional subsidization in a different pool to enable the cost of coverage to come down for otherwise healthy people. But concerns within the Republican Party following the CBO score went to, is it affordable? What the tax credit that they were proposing, they had removed the cost-sharing subsidies. There are some who think that there should be cost-sharing subsidies. There's some who think that there shouldn't. Most significantly, the role of the state versus the federal government. Whether there should be Medicaid reform and restructuring. They came out with $880 billion. That's a B, even by Washington standards. That's a pretty big number in Medicaid cuts over a 10-year period. They moved to create block grants and per capita caps. We're going to talk more about those. Insurance regulation, whether to keep the essential health benefits, whether to allow states to define what should be in their insurance plans, which was the way that it was before the Affordable Care Act, whether you should have or allow or protect people with conditions from having to pay more due to their health status and other consumer protections. So these were some of the issues that they were grappling with over the course of the development of the bill.
And I'll just quickly note from a process standpoint, the Congressional Budget Office has not analyzed the bill since the refinements happened that Lisa mentioned. So when the House failed to have a vote in March, they added a series of amendments to essentially make the bill more palatable to the conservatives and to the moderates who were opposed prior to the vote. And so we need to have that score for the bill to actually move to the Senate before they can consider it. So we'll have a better understanding of the coverage implications when CBO takes a greater look at the updated version that passed the House. So the Freedom Caucus, I'm sure you've heard a lot about them, and Lisa touched on it briefly. It is a faction in the House of very conservative Republican members. It is led by Mark Meadows of North Carolina. There are 31 members in this group. They were a big part of the negotiation process as the AHA moved through the House. After the vote did not occur in March, they spent a lot of sort of the congressional recess, a break period, over the Easter and Passover holiday, negotiating with the administration to find ways to refine the bill so it could advance. And given that they needed 216 votes, they achieved 217 when they did pass the bill. They were really concerned about getting this group of folks on board. So you can sort of see here what they wanted, and a lot of this they did end up having included in the final version to some extent, but they essentially wanted an immediate repeal of essential health benefits. That's not exactly what happened, but we'll discuss that in greater length here in a moment. Repeal of the community rating measure, there's a waiver that we'll discuss that was included as an amendment, and lower cost premiums. So these adjustments were made in large measure to appeal to this group, as well as the Tuesday group, which we'll talk about next. So the Tuesday group is sort of juxtaposed a bit to the Freedom Caucus. They're the more centrist, moderate faction in the House of Republicans. They're the Republicans in the House that are more moderate. We don't have an exact numeric number of how many are in the group. It's sort of a loose, organized group, but it's led by Charlie Dent, Tom MacArthur, and Stephen Nick of New York. And so they took a very hard line against the HCA in March. And so they also worked with the administration, and Charlie Dent, one of the co-chairs, worked with Mark Meadows, the Freedom Caucus, to come to a middle ground. And that's where we saw these series of amendments advance. So on the opposite side of the Freedom Caucus, they were really concerned about what the CBO said in terms of the loss of coverage of 24 million lives not being covered. Certainly concerned about high cost for the age population of 50 to 64, and then the significant cuts that the CBO score also demonstrated. So those were things that they wanted to be addressed before they would agree to vote for passage of the bill.
Okay, so we're going to talk a little bit about the major provisions of the legislation. I would note that it's 100 some odd pages. The Patient Protection and Affordable Care Act was 2,000 pages. So it's just a completely different approach in terms of how they designed their legislation. And there are a variety of political and policy reasons for that. So the first thing that they do is repeal the mandates. So what they replace the mandates with is a continuous coverage surcharge, so that if you do not maintain coverage, if coverage lapses for 63 days or more and you don't continue it, then the insurer will add an additional 30% premium to what you pay for 1 year. So they're really trying to push people to maintain continuous coverage. And really their goal there is to stabilize the marketplace and get more healthy people participating in the marketplace. And their other goal with regard to continuous coverage is to not be in a situation where, as they would describe it, there's gaming of the system where someone doesn't purchase insurance until they get sick, and then they purchase insurance, and what that creates is adverse selection in the risk pool. Basically, it means you got more sick people in the pool, cost more money. That's why premiums go up. And so that's their approach that's different from the mandates. Repeals the taxes that we talked a little bit about before, the major taxes, and they total it's like $900 billion collectively together. It's a lot of money. And then they would replace the premium tax credits and the cost sharing subsidies. The premium tax credits, as I mentioned, were based on income, and they went to replace that tax credits based on age. They made modifications along the way to phase it out for upper income families and individuals. But first and foremost, it's based on age, which led to some of the criticism that they had not provided enough of a tax credit to enable older individuals, particularly 50 to 64, before Medicare eligibility, to be able to afford the coverage.
Another piece of one of the major provisions in the HTA are some of the market reforms. So as you've heard us say time and time again, there's great concern about the stability of the market, and so one of the initiatives of this bill is to address some of those concerns. So adjusting things like the age rating from 3 to 1 to 5 to 1. It does retain essential health benefits, but does repeal them for certain aspects of the Medicaid population. As we mentioned before, it retains many of the consumer protections, but also repeals sort of the actuarial value requirements, which you may have heard of, the bronze, silver, gold, platinum products that were being sold in the marketplace. There's also state waivers, and so this was a series of amendments that were advanced, as we discussed, in an effort to secure greater support for the bill. And so there are 3 specifically that were advanced by MacArthur, who is a member of one of those factions that I had mentioned earlier, that worked with the vice president to address these issues. But one is to allow a waiver for states, and I should note that these are waivers that we do not think California will apply for, but certainly there are some states who will, but allows states to create a waiver or apply for a waiver for a state-specific age rating ratio beginning in 2018, allows states, if they apply for the waiver, to replace essential health benefits, so they would no longer have to meet the federal requirement. As Lisa mentioned, across 10 broad categories, states would have discretion to decide what those essential health benefits would look like in their respective state. And the one area that you've probably heard a lot about, and this is where the pre-existing condition piece sort of comes into play, is that a state could apply for a community rating for health status. So essentially they could change their underwriting requirements around health status if an individual did not maintain continuous coverage. So when you hear a lot of the concerns around pre-existing conditions coverage and what this bill would do, this is really what it's focused on. And so I should note that states can only apply for this waiver if they have a high risk pool in place in their state or some other funding mechanism to provide coverage for those, perhaps the pre-existing conditions, who have premiums increase as a result of the state applying for this waiver.
So just to underscore, so the bill retains the ban on pre-existing condition exclusions. The issue is the affordability of the coverage if you have a pre-existing condition. Does that make sense? Whether you agree with it or not is different, but just in terms of what it's actually doing.
And I will say, just on a sort of an ancillary note, Lisa and I were chatting earlier today about it'd be interesting to know how many people do have a gap in coverage for 63 days who might be continuously employed but move to a new employer and have a gap and cannot afford COBRA or another means to have insurance during that time period. So I think it'd be interesting to see some studies around that. So I sort of touched on this a bit, but one of the big pieces, and this is certainly an area where the moderate faction, that Tuesday group, said, we're going to perhaps touch essential health benefits and do some of the other areas that we talked about that could impact those with pre-existing conditions. They wanted to make sure that there was money going into the system to help those who have premium increases. Now, there are a lot of discussions on both sides of the aisle if this is enough funding or if it will address those concerns. But one of the big pieces of what the bill does is provide, in total, $138 billion in various forms to help with out-of-pocket assistance programs. So this is known as the Patient and State Stability Fund. The underlying bill provided $100 billion for states that would set up a reinsurance program or a high-risk pool or something of that nature. And then in the last few weeks, we saw a series of amendments come through that provided additional funding. One pocket is for $15 billion specifically around maternity coverage and for mental health and substance abuse disorders. There is another series of $15 billion that, again, will help create that risk-sharing program, and we can talk about that in more detail here in a moment, but to also provide additional funding resources to those that need it. And then finally, at sort of the 11th hour before the bill passed, there was another amendment that offered $8 billion specifically to address that waiver that I mentioned, where if a state applied, they could change their underwriting around health status if someone didn't have continuous coverage. This $8 billion is dedicated solely to those states that do adopt a waiver around that issue, and it's in an effort to assist those individuals that might see their premiums go up as a result of their state adopting that waiver.
Okay, so Medicaid. I think this is an area of great confusion because I have rarely seen the press report on it correctly in terms of what they're doing. So let's explain what they're doing. You have the expansion states and you have the non-expansion states. So the first thing that it does is it says if you are an expansion state, you can continue to serve and cover that population under 133% of the federal poverty level, but you can't go above and beyond that. The most important thing that it says is, but we federal government are going to reduce the amount of money that we're paying. So what does that mean? So every state has a match rate, and it ranges from 50 to 75%. California is at 50. And so when the state spends $1 to serve a Medicaid beneficiary to pay for their care, the federal government puts in $1 to pay for that care. Or if you're in some of the impoverished southern states, it's 75 cents on the dollar. Okay, so there is certainly not equity among the states in terms of what the federal contribution is. What the Affordable Care Act did was to say for the first 3 years, since we're telling you states that you need to provide coverage for everybody under 133% under federal poverty under your Medicaid program, the federal government would pay 100% of the cost of that for the first 3 years and then 90% thereafter. So the Republican concern about that is you're paying a higher amount of dollars for childless adults than for children or folks with disabilities or elderly, okay? From the state's perspective, this is critical funding that it has enabled them to provide the expansion dollars. So to grossly oversimplify, what the Republicans are saying is any individual Medicaid beneficiary who prior to, I think this one, there's so many different dates that are flying around 19, will continue to be grandfathered and paid at that higher level, but if they cycle out of Medicaid and become ineligible, but they're still under 133% of the federal poverty and come back in, they'll get paid at the regular match rate. So when you hear the press or folks talk about rolling back the Medicaid expansion, what they're rolling back are the extra dollars, the delta between the regular match and the enhanced match. Now, when you look at the impact of it, CBO looked at the impact of it and said a bunch of states are going to pull out, not continue to provide that coverage. And that's where you see from that CBO score of 24 million individuals would lose coverage, 14 million of that was Medicaid. That's their projection. In terms of major Medicaid reform, one of the most significant things that they did in the House bill, we'll have yet to see whether this will occur in the Senate, is to change the nature of the way that the federal government reimburses. So right now, if you become eligible, categorically eligible for Medicaid as a beneficiary, the state spends money, the federal kick it in, and it's an entitlement program, and it was designed that way from its inception 50 years ago. What the Republicans in the House have included is what's called a per capita cap. Basically, they subdivided the Medicaid population into 5 categories: elderly, those with blind or disabled, children, adults, and the expansion population. And they calculated the cost. They have a very complex formula to calculate the cost. And what they basically do is to say they're going to cap the amount that they're paying per beneficiary. So if a state goes into a recession, more people are eligible for Medicaid, they come on. So it doesn't completely remove the entitlement status, but it limits the amount that's paid per individual. They start based on a 2016 baseline, they inflate it going forward, and then they inflate it from there. There's never a reset. And elderly and disabled have a higher, they're at CPIU +1, medical +1, than the children and the adults in the population. There's never a reset. So they also included the ability for states to do a block grant. What's a block grant? A block grant is, I'm the federal government, hi, here's state of California, here's your block grant. It doesn't go up, it doesn't go down. This is what you've got to cover your individuals that are eligible. And as I said, it's really for children and the traditional population. Even if they enacted this, we think it would be very unlikely that the state of California would pursue it. There might be some southern red states or otherwise red states that might do it, but it would be pretty unlikely. The other thing is disproportionate share cuts to safety net hospitals under Medicaid. The ACA had some major cuts to Medicaid safety net hospital financing because of the assumption of increased coverage. And so the AHCA rolls back those cuts, first for the non-expansion states, and then for the expansion states. So it's billions of dollars worth of funding that would be restored to Medicaid safety net hospitals.
This is just a really quick overview. As we mentioned time and time again now, there was a series of amendments added to make the bill more palatable, to secure support in the House. So you see here the bill, the initial underlying bill was released in early March, and then we saw a series of amendments after the vote was canceled at the end of March. And so the most recent amendment was the Upton Amendment that was released the day before the House vote took place.
Go ahead.
So we mentioned the patient and state stability funding, and if that was or was not enough of a resource to help those patients that do have an increase in premiums as a result of their state applying potentially for one of those waivers or because of the cuts in Medicaid. This is a study that Avalier did. They are a think tank, a nonpartisan think tank in DC. They do a lot of sort of economic and research analysis around different issues, and in particular healthcare. So they looked at this right after the bill passed and showed that they believe that there would certainly be sort of insufficient resources to cover all of those with pre-existing conditions. So you can see here they broke it down by state. According to their study, California has 301,000 individuals with pre-existing conditions, and the funding that's in the bill could cover approximately 110,000 individuals. That's across the whole country. So according to their projections, certainly not enough resources, but again, do want to underscore that this is for states that apply for the waiver, and it's not something that we anticipate that California would apply for.
So it passed the House.
As I'm sure you have seen, there are a myriad of naysayers, beginning with organized labor, the hospital community, the large sort of hospital factions have all come out opposed vehemently. So the physician community, the American Medical Association, the American Academy of Family Physicians, all the large physician groups have come out opposed, as well as major patient organizations, ARP, Families USA, and every Democrat that is a member of Congress.
I love political cartoons, so this is the one that we wanted to include. Just because the House did it doesn't mean that the Senate, the founding fathers designed the Senate to be very different than the House. The Senate is the deliberative body. The House pushes through legislation only to have experience quicksand or die in the Senate very often. And so the Senate shred-o-matic is already in motion with regard to the House bill. Go ahead.
So, as I mentioned, we're still waiting a couple of things process-wise before the bill can truly move over to the Senate, and one of those is that CBO score. But once the score occurs, the bill will move over to the Senate, where the Senate parliamentarian will vet it and scrub it to make sure that it meets all the procedural components that Lisa discussed at the beginning of the presentation. But senators have already indicated that they're not going to just take up the House bill and pass it. There are a lot of concerns on the Senate side about many of the provisions that were advanced in the bill. And so there is now a working group of 13 senators who are beginning to craft their own legislation. Some of the early reporting has indicated that they will work on a bill and then move it directly to the Senate floor. I think it's still unknown if it will make its way through the committee process or just advance to the floor for a vote, but they're certainly cooking something up as we speak. As this notes, the Senate moves at a much slower, more deliberate pace. And so I don't think we'll see sort of the urgency that we saw in the House when they advanced the bill. Now, what's really of significance, and I sort of touched on this earlier, is that passage in the Senate is much more challenging than it was in the House. And in the House, passes by the hair on their chins. The Senate can only lose 2 Republican votes to advance this bill, and there have already been a number of Republican senators who have been quite outspoken with concerns in the bill and that they would not vote for the bill in its current form unless there were significant changes made. As I'm sure you've heard, Senator Murkowski, Rob Portman of Ohio, and others have indicated that they would need to see those changes. So securing their support is going to be imperative for them to move something in the Senate. And what's of most significance is that this is not even the end of the process in the House, because the Senate will undoubtedly sort of work up their own bill. They will need to do a conference where the House and Senate get together and sort of hammer out the details of this bill. So it's also a political question of, will the House approve a bill that is likely very changed from what they passed out of their chamber? So as you've heard us say time and time again, this is very much not the end product. It's still very much the infancy of this process. This is also an opportunity where you, as citizens, as patients, as leaders in your industry and your community, have an opportunity to weigh in with your senators about components of the bill that you support or you would like to see modified. And so I would encourage you to do that as constituents.
Okay, we're going to move on to some other healthcare issues that are out there. All of the wind and all of the noise is around the effort by the Republicans to repeal and replace the Affordable Care Act, but it was going to be a very busy health year under any circumstance. And the reason for that is because they delayed a number of decisions until after the election on a bipartisan basis around some major pieces of legislation. And here they are in a nutshell. Reauthorization of the FDA user fee agreement. So what funds the FDA for, they're called the UFAs in Washington speak, but all three of those for generic, pharmaceutical, and device need to move through the legislative process. That's already begun on a bipartisan basis. The issue of drug pricing could come up. It's an opportune time for those who have concerns about the high cost of prescriptions to be raising them. And we certainly have seen a number of folks on the Democratic side of the aisle. Senator Warren, Senator Sanders have been out with a number of proposals. So we expect that this is going to be debated. The Children's Health Insurance Program, which was enacted on a bipartisan basis and has been supported on a bipartisan basis, has to be reauthorized. Legislation like that typically has a 5-year, sometimes longer, but typically a 5-year authorization, and the Congress comes back at the end of the expiration of the authorization and makes whatever changes that they want to. We expect that this will be bipartisan, largely. Medicaid dish cliffs. You remember I talked about the cuts. So the American Health Care Act, as proposed by the House Republicans, would claw back the cuts. Basically, they'd restore the funding, but current law, in the absence of any additional congressional action, either through the AHCA or otherwise, those cuts are going to start coming due. They've been pushed back several times on a bipartisan basis by the Congress, but the first round of cuts is coming due October 1, $2 billion to states to fund safety net hospitals. It's a lot of money. Community health centers. So community health centers have their authorization, but they need funding. They have been supported on a bipartisan basis. Don't expect a lot of major changes there. Cost-sharing subsidies, we'll come back to that on another slide. And the Medicare extenders, there are a number of provisions that get done over and over again, whether it's pushing back therapy caps or the ambulance additional payments that they receive. And so they come back and they extend them. They would like to address these in a more permanent way, but a number of those provisions are coming due somewhere between October and the end of the year. So we expect that they're going to be moving either together, all of these issues, or separately, a number of legislative vehicles.
So one of the things that this bill does is essentially replace the cost-sharing subsidies, which is a way to limit some of the exposure that patients have for out-of-pocket costs, and replaces those with those tax credits that Lisa mentioned that sort of increase with the age of the patient. Now, this is something that's come under a lot of political scrutiny for the last several years. It's something that Congress, the Republican Congress, indicated that they did not appropriate as part of the ACA when it was included, and so there has been a legal battle about cost-sharing subsidies for quite some time now. And now that we've had a change in the administration, essentially Congress is in a legal battle with its own administration, which is a bit of an odd predicament to be in. And so they have elected to not sort of move forward with the litigation, but instead to have an update and a series of reporting about what's happening in the space. The next updates to occur on May 22nd. So what's significant about this is that this bill, the HCA, actually repeals those subsidies. And so if this advanced in the Senate, the question is, would that be included? There were some efforts to address this in the budget, but because it was so controversial, they did not. So this is an area that, if advanced, could really have significant implications for patients, for hospital systems, for insurers, certainly. And that is of significance as the insurers make decisions about staying in or outside of the marketplace in the coming year. So as we mentioned, a big piece of HCA was an effort to stabilize the market. There are a myriad of concerns that insurers have about the current environment. So outside of the legislation, the administration advanced a rule, and we saw the final version of that rule a few weeks ago, and it makes some changes to the open enrollment periods. It condenses them. It eliminates the federal requirements for review for network adequacy, and it instead shifts that responsibility to the states. And essentially gives a lot more autonomy to the states. And so it was sort of the first effort at stabilizing the marketplace. So as I mentioned, insurers have until June 21st to decide if they will participate in the marketplace next year. A lot of insurers have already taken action around this, but some of these efforts that you're seeing move forward are an effort to make sure that these folks do stay in the market. So in part, that's what the final rule was hoping to do. In part, that's what the Republicans are hoping to do with the HCA. But we've already heard from Aetna and Humana and some others that they've scaled back their participation significantly. And there's others who are making those decisions as we speak. And again, those will have significant implications for the marketplace moving forward.
This is a slide that was produced by the Center for Medicare and Medicaid Services. And what it really shows you is the federal government's long-term desire to change the way that healthcare providers are paid, so that they're paid not on volume, paid on value, but what you see, this is their slide, a movement toward a global capitated rate. And all of the quality programs are a step toward that ultimate goal of the federal government. So it's important just to keep that in mind as we move through. Go ahead.
And that slide is around Medicare. So as I mentioned, nothing in the Medicare space is shifting under the HCA. And so that was a slide from the previous administration, but I would argue that that goal of transitioning from volume to value is something that will still be held by this administration. The timeline in which they advance it might be tempered under the new administration, but there's certainly an expressed desire to continue to shift outside of fee-for-service, and this slide sort of illustrates some of that. One of the goals by the previous administration was to have 30% of fee-for-service payment under Medicare transition into things called alternative payment models. Some of them are outlined on the previous slide. They succeeded in that, and in fact were far outpacing that goal, with the goal to reach 50% of transition from fee-for-service to alternative payment models by 2018. Very quickly, for the clinicians in the room in particular, MACRA. MACRA is the Medicare Access and Chip Reauthorization Act. It was advanced in 2015. It is perhaps one of the largest overhauls for the Medicare space since Medicare was introduced in the 60s. It is the transformation of Medicare for what HCA is to Medicaid. And so we saw the bill advance in a very bipartisan nature, actually supported highly by Dr. Price, who is now, as we mentioned, at the helm of HHS. But it replaced an old antiquated formula in terms of how physicians were reimbursed, where Congress had to step in every year to avoid significant cuts to physicians. So this repealed that formula and instead creates sort of two new pathways, two new paradigms for physicians to go under to receive reimbursement. So one is MIPS, which is a series of quality reporting initiatives, and then the other is those alternative payment models that we briefly touched on. So there's a series of legacy programs that are being sunset and harmonized under one umbrella, so things like the Physician Quality Reporting System, HR Meaningful Use, the value-based payment modifier. They'll still exist, but now they're under this umbrella called MIPS, where clinicians will have to do a great deal of reporting to adhere to these metrics. This is the timeline that shows that physicians can receive, and it's not just doctors, by the way, this also pertains to NPs and others in the clinical space, can receive upward or downward payment adjustments based on their performance around cost and quality under the MIPS program. So if you want to avoid the MIPS program and jumping through some of those administrative hoops, the other opportunity is to participate in an alternative payment model. As you saw on that slide, those are things like accountable care organizations, bundle payments. There are 7 sort of blessed alternative payment models for this year for providers to engage in, but the bar to engage in those is very high. And so at the onset of this program, we'll see most providers in MIPS, but hopefully transitioning the agency's desire for them to transition to APMs in the future. This I just quickly touch on because the hospital that you were sitting in is actually engaged in this payment model. There is a huge effort to start starting bundled payments. The rule has been delayed, but it's an effort to bundle payments around certain cardiac conditions. I think we'll see this space grow and grow around other conditions in the future, so just wanted to flag it because it's certainly an area that we're going in healthcare moving forward.
So just some key points, this is our last slide. Ultimate enactment of repeal and replace this quest by the Republicans is not certain. And even if they accomplish it, it certainly isn't going to be what you see passed by the House of Representatives. It will be different. The issues that the Senate is grappling with are many of the same issues that the House grappled with around Medicaid funding, particularly what happens to the expansion states like California. And then you have the senators, Republican senators from the non-expansion states saying, wait a second, we didn't expand. Do we get to, So that conversation is going on. Protection for individuals, the consumer protections, that's going to be debated. Premium tax credits to address affordability. And California isn't expected to apply for any of the waivers, even if they are included in the Senate legislation, at least as they were designed in the House bill. We couldn't imagine that if what was ultimately enacted was a block grant, that California would go for that. Some states will, like Florida. Current Florida governor is just champing at the bit, but we just don't see that happening here. But California, under what they're discussing, if they roll back the enhanced funding for Medicaid, that would mean that California would either get less money covering the same amount of people, they'd have to raise taxes or adjust the budget or whatever. So certainly, if there is a rollback of the enhanced funding for the Medicaid expansion population, that will have an impact on California and the individuals who receive insurance in that regard. And just last but not least, the California exchange, as we talked about, is certainly more stable than other parts of the country. And that's good for you. So hopefully that will continue. But in terms of the impact of some of the changes that they've proposed, not really clear. Okay, well, I guess we've tired you out. So thank you very much for your attention and for not shooting the messenger.